Welcome to the 5th QHSC training and logistic meeting. So we do this meeting every week to try and catch up and try and figure out how we can effectively provide the education and training, not only for one day, but we want to do this for the long time. Like, we want to make sure everybody, so we were trying to make sure we make the training effective, meaning like we have to train or educate our colleagues in Tanzania using things that they can apply and make it effective for what they're currently doing. We have had a few training, which I'm going to go over it in a few minutes, but our goal is to share knowledge, share best practice, share evidence-based practice, and try to improve care. Our ultimate goal for every healthcare worker is to make sure you're improving the patient's life, and at the end we save lives. So you are going to hear a lot of expertise in the group. So some of the time on the training, we all have the same goal, that's to improve patient care. So today's agenda is global training. So we're going to go through the list of the training we've done, and then we're going to review what the takeaway from last meeting, which was June 3rd, and then all business that they still need to be discussed. And then we're going to open the floor for everybody else. And okay, starting with the training, we have had already 3 sessions and going 4, 5, 6, and wherever we can get. So the first training was in May 19th, which was covering neonatal health and neonatal resuscitation. That was provided by Dr. Lilian Msambichaka and Dr. Zaveri Banera from Mwananyamala. Dr. Lilian Msambichaka from United States. So we were like to have people who attended. There were about 20 people. The next training was on May 26th. That was neonatal temperature and glucose changes. Dr. Fabian Ngido from US and Dr. Martha Mkonyi from Tanzania provide those training. And we have about 40 people there. Sometimes it's hard to have an actual number because sometimes people log in with the phone, and then when we ask you for their contact information, so we'll be able to count, it's hard to know who attended through the phone. And that's why I put it plus. So it might be like 42 or 43 because we didn't have the number to call them back or to access more information from them. The last training was in June 9th, which was about ventilation demonstration and skills. That was Dr. Fabian Ngido from US and Miss Emily Rosenberg, that's a nurse educator from US also. And we had about 35 people, because some of them were people in the group. You can hear them on the phone in a group, but we don't know how many of them. So that's why I put 35, around 35. We still have more training to go. The next one, at least as of now, we know is fetal monitoring, which was requested by Mwananyamala groups and was echoed by Muhimbili and Buguruni, that they do need to improve and include the consistency when you're assessing the moms before the baby is born. Because after hearing those 2 sessions, how we need to prepare for the baby, so it makes sense that we need to address the moms and then to make sure we have those identify risk from the mom's standpoint to be able to prepare for the baby. So anyway, so the training for fetal monitoring, it's a lot of information. So that's why we break that class is going to be in 2 sessions. One of them is going to be June 30th, and the next one is going to be July 14th. And that one is going to be provided by Dr. Emma Wakuru Mukeri from US, Professor Michelle Brown from US, and Mr. Jafari Utavi from Muhimbili, and Ms. Neema Minja from Buguruni. So we're going to have a tag team for those 2 sessions. We're trying to do all those sessions under an hour just to make sure we capture the healthcare workers who are at work. Sometimes it's harder to go more than an hour if you're on your schedule. So that's why we have to break those classes in 2 places. State topics are being discussed, obstetric emergencies. That's going to be mid-June and beginning of August. The dates are going to come in. We're going to aim to do all the training on Thursdays, 7 in the morning from US, and then 2 o'clock in the afternoon from Tanzania. And then so for that, obstetric emergencies, Dr. Gwen Randall, Mr. Bashir Mari, and Dr. Gwen Randall from US, Mr. Bashir Mari from Buguruni, and Dr. Moses Murungu from Muhimbili. So we're going to work together to make sure we get that group going. And then the next group is going to be screening diabetes, pregnant women, protocols and at risk. So we're still working on those. We're going to fit in on those some of the days that those Thursdays are left in between. And then neonatal hypoglycemic, Dr. Fabian Ngido, and is working with his group to give us the date, and then we're going to update as soon as we know. And the last one, but not least, postpartum hemorrhage, that's the big one. So we're going to still add to some of those days that are left before, because we need to teach that before we get there, at least 2 sessions. And then when we get there, we do the mark drill, which mark drill is just like evaluation skill, the role playing, make sure everybody knows what they're doing, because by then they have the theory part, and so be able to demonstrate the skills at that time. So those are the topics as of now, and I know there's a lot of requests, but we have to focus on the certain things that are also included in the medical mission. So when we get there to the medical mission, we're able to provide those providing those training, face-to-face demonstration, skills evaluation for what we have taught. And it's easier to do that way because at least we know how much knowledge you have at that moment. So then it's easier to demonstrate versus doing something new at that time because we don't know where you are with that knowledge. So that one. But as we said, it's going to be an ongoing, and that's why we're working with the Minister of Health. And thank you, Mr. Mbada, for being here today, because you're going to help us get more information and hopefully answer some of the questions that we have in order to make an effective planning of this education. Any questions so far on the schedule? Oh, Dr. Msambichaka, you have a question? Yes. Okay, I'm going to come off my screen. Dr. Msambichaka, go ahead.
Yeah, so the question is the helping babies breathe. We don't have it on the schedule.
Which is the date?
Well, we don't have a date yet.
Oh, so as soon as we get the date, we can add.
Okay, I'm anticipating 2 sessions.
Yes.
So maybe sometime in July or even August.
Okay, no, that's fine. Yeah, so we can put one in July, one in August, or if we get July, I think the first week of July is still open, but I think it's accompanied with a holiday, which is a few days before. That's fine.
Yeah, it probably have to be like probably towards the end or probably even August. And then for the hypoglycemia protocol as well, for the neonatal one, we'll let you know the date. It's going to be Dr. Akita and myself that are going to do that.
Okay. Okay, so I'm going to change from Dr. Msambit, from Dr. Fabian. Okay, hypoglycemia. Okay, perfect. Cool. Yay, Dr. Akida, thank you. Okay, so let's go back to what we discussed, and then I'm going to let Mr. Mbinda to come and introduce himself here. Oh, in fact, before I let him speak, I'm going to ask almost everybody who is here, so introduce yourself so at least he knows who is here, and then he'll be able to, when he's addressing his questions, then everybody will know who is here. So let me go over what he needs to, he's going to answer that, but this is from takeaway from last week, and then so I will let him speak after that. So takeaway from last week. So we're still, because last week we had only Mr. Saturini and we didn't have representation from other hospitals. So we wanted to make sure at least if Mr. Saturini can make a follow-up and have a few representatives from each hospital. If the main person is not able to come and we know the schedules, at least we have attendees from each hospital so they can at least give us some feedback and they'll be able to continue planning and continue working with this logistics. So I know Mr. Saturini is not here, but Mr. Mbana is going to give us the updates. And then timeline from transportation. So we did have a discussion with a number of hospitals, and we wanted to know if a patient is being taken care of at the hospital and then there's an issue there at the hospital, they have to be transferred. So we wanted to know the process from the person who is transferring to the hospital that the patient is going to, and then what kind of communication do we have, and then what information specifically that the patient will receive as they're being transferred, the care during the route, and then receiving hospitals. So we were fortunate enough last week to have, on the 4th, we have a discussion with Buguruni. So their team, there was Mr. Bashir and Miss Neema came and discussed things that logistically could complicate the movement or the transfer of the patient from one area to another. And then, so one of the takeaway also is the timeline, like how much time is needed from a patient coming from one area to the next And from there, we got feedback from Buguruni to Amana, which is the second level from them. It's 20 minutes, like 15 to 20 minutes, depends on those on the traffic and all the stuff. And then from Amana to Muhimbili, it could be almost like, from Buguruni to Muhimbili, it could be up to 35 minutes. So 30, 35 minutes with traffic, and we know traffic in Dar es Salaam, sometimes it may be different on the time of the day. And then, so knowing those time that if the patient is sick enough or severe enough, needs to be transported from one area to the next, and you know there's a 20 to 35 minutes of transfer before the patient get to the next hospital, that is the critical area that we want to make sure what the training is there for those people who are transporting that patient, and what information is gathered during the transport to try and relay that information to the receiving hospital. So we had a good discussion with that. We need to do the same thing for Muhimbili. If the receiving patient, how much preparation do they have, or what documentation do they have? So that's the part is ongoing, and I hope we're gonna get it from the future meetings. Also, we need to discuss about the protocols, the current protocols. What do they have right now set, like from the regional area to from one hospital to the next? So those are things that they were supposed to be sending the information. We've not received some of them yet. So once we receive, we're gonna probably including in our training, which Dr. Gwen Randall is gonna be involved in the training from one area to the next. So when you guys share your protocols, that helps us to be able to address and plan the effective training. And I think Mr. Saturini was supposed to follow up with that, and then so that he can give us an update. Another thing we were discussing that time is if we have one hospital going to the next, so the transport part, the care should be the same in every hospital. So I'm talking about the patient who is receiving care. So if the patient is from Muhimbili, Buguruni, and it needs to go to Amana, when you are transporting that patient, the person from Buguruni needs to talk to the person from Amana, and then the person from Buguruni also needs to talk to the patient, the doctors who are receiving the patient to the other side. So knowing that, we want to make sure we have a consistent system. So every nurse, every doctor know what are the criteria the patient should have, and then how do they transfer, how much time do they need to be taken between identification of the patient being that sick to the receiving hospital, how much time is left, and how can we shorten that time to save somebody's life. So those are a discussion, ongoing discussion, and we needed to know here from Muhimbili and Mwananyamala. We did get a little window of opportunity in Buguruni. They shared what they do currently, and thank you very much, Mr. Bashir and Ms. Neema, for sharing that information. Another thing that we were hoping Mr. Saturini will provide for us is the list of all the healthcare workers who will be receiving the training when we get there for the medical mission. So yes, we are doing the training right now, the theory part. We want people to get that theory, and that's why I keep asking them to give me the names of people who are attending, so we know how what the percentage of people attending the training now virtually. Then when they get to hands-on, how many people are going to be there, and what percentage are people who are going to learn that that training. The reason we want that is because all those three hospitals and Ministry of Health have asked us to provide to address newborn indicators outcome, to make sure we address with our training to what they need to measure. Before the training, the statistic was this, and then during the training, okay, we are improving, and then at the end of the training, what exactly is happening? Did they gain? Did we save lives? Did we improve critical competencies to these people? So all those things, in order to move that dial, we need to have the number of people attending those trainings. So we were asking the leaders from all these three hospitals to bring and make those logistic plans to make sure those people come to the training, and then so they can get that knowledge when we come to do the medical mission, we have enough number of people to attend and be able to give them consistently the same education that they need to get all across the board. And that's the only way you're going to change those neonatal indicators to make sure you improve the care. If we have less than 50%, that's not going to work, because if 50% are trained using evidence-based best practice and then 50% are not training. So when you're taking care of the patient, of that 50% who have not received training, that care is not going to be the same. That child, the child or the moms who is receiving those emergency care are not going to get the same care. So you're not going to improve anything with that, because if the maternal mortality is going to increase or it's the same number, it's going to be the same no matter what. We have to have more, preferably 100% of the trainees. And that's where the logistic part comes, that we need to have those leaders work with us to be able to include people to come to attend. And that's why Mr. Saturini was going to get the list of the people from each hospitals that they're going to be able to come to attend the training during the medical mission. I know Muhimbili have 219 nurses. Thank you, Madam Zuhura and Mr. Jafari, for providing that list. I mean, the number of the nurses who we are be able to attend. And you have indicated that 100% of people should attend the training, which I agree with you. In order to change those statistics, we have to have close to 100%. And then I think those are the ones what we wanted feedback from Mr. Saturin. So now, since we don't, sorry, I'm trying to share this. Since we don't have Mr. Saturin today, but he was gracious enough to send Mr. Matthias Mbida to come and join us in this discussion. So I'm going to welcome Mr. Matthias Mbida to come and introduce yourself first, and then let the group introduce themselves, and then you're going to go answer those questions.
Okay, thank you, Dr. Gabon. I'm really happy to join with you discussing this issue, because this is I'm very interested with this part. I did a lot of research on this area. As you can see in the group, I've just sent my research that I did during my master's. So this is my area of interest, because I've seen a lot of problem with this area. If you want to improve these areas in the issue of neonatal resuscitation. So I'm so glad to be with you here. So my name is Mr. Matthias Mbida. I'm from the Ministry of Health, from the Department of Nursing and Midwifery Services. So I'm a pediatric nursing specialist, so I'm glad to be with you today.
Thank you very much. We appreciate your presence. Definitely, we need your input. And as you said, this is your area. Help a baby breathe. We want to make sure every single person, I know I've said this before and I'm going to say it again, every single person who touched that baby, they better be trained, because that baby deserves the best care possible. It doesn't matter if it's a Buguruni, it doesn't matter if it's Mwanamanyamala, it does not matter if it's Muhimbili. Every single baby deserves the healthcare worker who knows what they're doing to take care of this baby. So thank you very much for coming here. So I'm going to let people who are here introduce themselves quickly, just your name and your credentials. And then, so when Mr. Mbida is responding to those questions, then he knows who are people in the group here. Go ahead. Maricela is going to be the first one. Maricela, can you introduce yourself?
Sorry, I couldn't go. Hi, my name is Maricela. I am a nursery student at South University. I have the pleasure of having Dr. Gabone as my teacher, my venting person, my psychologist, my therapist, you know, all that good stuff. But nice to meet everybody here.
So, and you're going to be at the medical mission, working on the Help a Baby Breathe and the thermoregulation and stuff. So we need your help there, Ms. Maricela. Okay, Ms. Hunter, I see you next in my screen.
Hello. Down. My name is Hunter and I'm a nurse 3 student, just like Maricela.
That's fine.
My name is Brian. I'm also a nursing student at South University. So going to Africa for the first time, very excited.
And so both Ms. Brie also is going to be working with postpartum hemorrhage, and so part of the transport right there, and the thermoregulation part of the baby also. So we are still trying to have them being involved with the process for the training, just to understand when they're coming to do training with our colleague in Tanzania, what is required and what is the expectation. So I just gave them a little opportunity to come and learn the process, how it's needed, especially for them, 3 of them being involved in the medical mission. We want to make sure they understand the process when they come to outside the country to come and teach people, other healthcare workers over there, so they know exactly what the process is, and then so they can provide the education if needed. On next to my screen is Mr. Siakabe.
Hello, everyone. My name is Parang Siakabe, and I'm the Vice President with Dr. Gaboni QHSC. Pleasure to be here.
Sorry, I'm on the road. You can't even see me.
Okay.
I'll probably just turn off my video. Yeah, my name is Dr. Lillian Msambichaka. I'm a pediatrician. I'm actually currently in Tanzania, and I've had the pleasure of meeting people at Mwananyamala and Buguruni, and very excited.
Thank you, Dr. Msambichaka. I see Dr. Akida.
Oh, my name is Dr. Mkiwa Akida, working at Mwananyamala. My profession is pediatrician, the very new one, working in neonatal units.
Thank you. We can't wait to see you when we get there. See, I'm going to come with my 3 ducklings to come and learn from you guys, so that's good. I see Dr. Robert Moshiro. Yay!
Yay again.
Hello, good evening. I'm Robert Moshiro. I'm a pediatrician working at Muhimbili National Hospital.
Thank you very much for coming, definitely.
Good to see you, Robert.
Yes, good to see you, and we can't wait to see you in Muhimbili. Remember last time I brought my other nursing students and nurses, and then so now I have 3 more, so they keep growing. Before you know, I'll bring like 50 of them to Muhimbili. Okay.
That would be very nice. Karibu sana.
Asante. Mr. Jafari.
Hi, everyone.
Hi.
My name is Jafari Utavi. I'm a midwife. I work at Muhimbili National Hospital as a midwife.
Okay. Thank you very much, Mr. Jafari. We can't wait to come and see you in September. So we have so many people to come and work with you and teach and train everybody. So that's good. Thank you. And Mr. Jafari is going to help us with the fetal monitoring training. I don't know if you knew that, but and also postpartum hemorrhage. So it's going to be part of the group. So thank you. I have Miss Valentine.
Hello, everyone. My name is Valentine Dantes, and I was part of the mission from last year, and it was such a beautiful experience. Right now, I am QHSC's secretary, and I'm so sad that I can't go this year, but next year I will be there for sure as a registered nurse. And I'm so excited for all of you South University students who are going this year. You're going to love it.
Yes, so Mr. Dr. Mushiro, remember Miss Valentine was there last year with us, so with the medical mission. Yeah, so she really wanted to come, but unfortunately, other logistics happens, then she can't come. But we're good. Thank you very much, everybody. Did I forget anybody? That's all I have on my screen. If not, so if everybody, I'm gonna let Mr. Matias Mbida to come and give us the feedback updates for what we were asking Mr. Saturini to get that information for us. Mr. Mbada.
Okay, thanks a lot, Dr. Gabon. As I've been told with my director here, some of the issues that were just pending regarding from the previous meeting, which I was not there. The issue of asking that I just go randomly because I was speaking from and bring the screen here, it will be better.
You said you want me to bring back the presentation, the screen?
Yeah, he's muted right now.
I can hear.
We can hear you.
Yes. Starting from the issues of this one discussion and follow-up, I'll start with the second one.
Okay.
Disregard. Yes. What I've been told with my director here, just to give feedback on you, it was just starting from the number of people who need to be trained regarding the issue of neonatal resuscitation. That what I got here is from Buguni, I've got only sent me 14 people. And then from Mwananyamala, there are 36 people. And those from Wimbira, we just had a little time a bit. 200. Hello.
Yeah. Hi.
Are you getting yes? The total number from these three hospitals, and from Buguluni, Mwananyamala, and the Mwimbili National Hospital, is 340. 340 healthcare workers that have been need to be trained in neonatal resuscitation, starting from that time that you told that will come. And also, I've been told that you have asked for the referral protocols. Yes. I've been told that we are just organized because this hospital from the where those protocols that they have on defining the patient from one place to another. That's what the issue that are being told that is these also are working they are in different areas. So some of the areas they have different protocols from one place to another. How do they receive the baby from one place to another? So I have to communicate with the people from Buguni, Mwananyamala, and Nechi to send me the protocol that I have, they have, and then we just look and then that we pass from it, and then you just deliver it completely. What do they do? If they want to send the baby from one place to another, what do they do? What do they do? If they, what kind of issues do they consider from sending the baby from one to another? Because those babies which are being transferred from one place, they have different conditions. So what we see, we must have the standard of what are they doing if they want to send the baby from maybe from Buguni to Mwananyamala or Mwananyamala to Muimbili. What things are they doing? So this issue, I just communicated with the people from Buguluni, Mwananyamala, and Muimbili, and then I will let you know what protocol do they have, because I think that they have different protocols from different referrals from different places. As you can see, that Muimbili is just a national hospital, so they receive a lot of patients from outside, from over all the countries, even from Dar es Salaam. So I think they have different protocols from Mwananyamala and Buguluni. So we just see them, what they have, and then we share it together.
Okay, yeah, so I do expect that Muhimbili is going to have, I mean, it's a referral hospital, so it's going to have different levels of acuity or getting those patients. But the basic things in transport, either from lower level acuity to mid-level to higher acuity, the basic things of transferring the patient is still the same. Like you need to have vitals, you need to have IV, you need to have airway, you need to have medication standby if the patient, for example, is bleeding. So those are basic, even if it's a lower level hospital, because they're transferring the patient to the higher level, they have to prepare the patient to go there. So there's something should be the same. But yes, if Mwananyamala is transferring the patient to Muhimbili, yes, they might add other intubation or other stuff, but still the basic things that the nurse should have to do during transport, it should be still the same. So in the protocol, it can be like maybe level phase 1, phase 2, phase 3, but every single hospital needs to have phase 1, because that is the standard. It does not matter what equipment you have, anything like that. So yes, when you get those 3 protocols, then we look at it and try to mesh them or marry them to make sure if I'm level 1, I'm transferring to mid-level, I have to prepare the patient so there we go and continue doing whatever they need to do. But those things that I might be doing still has to be for every single person to stabilize the patient. So that's fine. That'll be great if we can get those protocols and then build on it to make sure that, the person who is transferred from lower level to this mid-level, they should expect that the mid-level, high level is going to require, let's say, I don't know, secondary visit. I'm just giving an example. Or they might require something else. So we have to do it en route when the patient is getting there. So that'll be good.
Okay, yes, doctor, I understand you, and that's the way it is. was three things. I'll just answer regarding the number of staff that need to be trained. That's the protocol, and the last thing was, that's good. And then needed a list of faith. That's already available in order to establish current baseline newborn outcome indicator. The QHSC. Okay, this the last one regarding the indicators of the newborn. See, they haven't much research done in this area in your country. I think we are still behind. We are not going to the same way to that the Millennium Goals, it says in 2025 or 2030 to have the less than 7. I think we haven't reached that area. So we need to be to establish some method to combat this problem in our area, because we have a certain problem where this area that we still have a problem in just inadequacies in performing this neonatal resuscitation in our areas. Different. If you go to some of the hospitals, as I told you that I did some research on that area, people, they have the knowledge. They have the knowledge that they have to do something like in neonatal resuscitation. If you ask the people regarding the knowledge, what do you have to do in neonatal resuscitation? They just answer very correctly. But the problem is in hand-on skills, according hand-on skills, how to perform that. That's the big problem we have in our country. If we say concerning the knowledge, people, they have knowledge. They're explaining a lot of things regarding what is needed in neonatal resuscitation, what equipment are needed. But the problem is hand-on skills. What should they do? If we let's say the last data, almost what we have, I think we can see that some of the researchers have told that is 30 to 1,000, some of the rate of neonatal death regarding neonatal resuscitation that we have currently. That I think 30 something, and some of the researchers, they say that is to change. So the biggest issues what we think we should consider here, I think is that as we talked earlier, is just on dealing with this on-site mentorship regarding the hand-on skills, how to example, how to position the baby, how to bag the baby, how to do those steps regarding neonatal resuscitation. Hand-on skills, that's a very important area in this issue. But regarding the knowledge, people, okay, they're explaining everything that's in it. That's what I have regarding that issue.
Okay, so I do understand. If I can paraphrase what you just said, for the to improve those indicators, newborn indicators outcome. That yes, people might have the knowledge, but the skills, and that's the part I believe as an educator. You can't ask somebody to do skills check or verification or the return demonstration if you don't know where the knowledge level they have. And the only way we can measure that is to give them training right now, so we know if we come, we know where they are. And that's why we want to do virtual first before we show up there. Because yes, we could have just come in September and just offer those help baby breathe skills right then and there, and then with an assumption that everybody knows what we're talking about. So most of the time, to make effective training is you need to know, you have to have the knowledge assessment for that person who is coming in. And the only way we know for us, because people have been trained different levels, so only person we know is to make sure we give them training now. And that's what Dr. Msanduchaka and her team in the Help Baby Breathe, they're doing all the neonatal resuscitation training, like hypoglycemic, ventilations, all those skills. We need to make sure they have the basic, so consistent basic. We don't mean that they don't have it now. I'm sure they do, but we want to make sure for what we are going to teach, we want to make sure they have what we are going to ask them to demonstrate back, to make sure all the consistency of the clinical training is for everybody. And that's why we want a good percentage of people to come and attend, to get the same information from the facilitators. So then when we ask you for the demonstration, we get the return demonstration effectively. And then we can improve those indicators. Because right now, the knowledge they have, you still have those certain number of indicators that are happening right now. And that's why we wanted to have the best number of you guys, like, those neonatal mortality and all the stuff. And so we want those numbers to know. So when we start teaching and training and demonstrating and asking verification, I'm sorry, of skills. When we have that and continue training, we want to make sure a majority of the people are coming to the training to have the same information, and then they can apply the same clinical skills, and then we improve the practice now. So it's hard for us to come and ask somebody who has been taught from somebody else, and then we don't know what the level of the education was given or what skills they were given during their training, and then for us to come and assess it because I don't know what they were taught. It does not mean that it's wrong. No, it's just probably somebody, whoever taught them, have used different evidence-based, different criteria to teach those stuff. So for us to come and effectively evaluate these healthcare workers, we have to make sure we give what we believe it's appropriate for you guys to use. And that's why we always inquire what you guys are doing so we can incorporate from the training to make it effective for you guys, so we don't want to waste your time. We want to make sure we give you something that you can use every day for practice. So I agree with you that they do have knowledge, but we want to make sure whatever we want them to have evidence-based best practice as of now is through the training that we provide, work with you guys. And then when we come to do demonstration, so everybody perform at the same level, and then we can improve the care. So definitely we still need to have a lot of people who are coming to, we come to attend those training and improve their clinical skills. Definitely. So thank you very much for that feedback on the number of the, for the newborn indicators. Dr. Msambi-Chaka, do you have any questions? Or Dr. Mushiro? Dr. Akida, do you have any comments?
No, my dear.
No, okay. Dr. Mushiro?
Not at this moment, Harriet, thank you.
Okay. Ms. Valentine, do you have any questions about the training?
No, I don't. Thank you.
Okay. So I just want to bring back Mr. Mbida. You said the number of the people who are going to be getting training when we are there. For Buguruni, you said how many? Kira, did you raise your hand?
Yes, yes.
Okay, go ahead.
I was asking if you can add some more of people from Mwananyamala, because when I was told there is a meeting, I was just asking some people to write me the names of the staff from neonatal, labor ward, and antenatal. So I was asking if I can add some more number of people from Mwananyamala.
Yes, please. If you can, that'll be great.
Okay, okay. I'll send to Mr. Usimba.
Okay.
All right.
And then he can share with me, yes, definitely. That would be helpful because we want to make sure a lot of people are getting that education. I know as of now, I know Mwananyamala has given us quite a bit of the people. I think yesterday was like 7 or something. I'm sure it's more than that. And then previous time there was like 14 and 12. So I'm assuming there should be more than that. Because remember, we'd be like all the neonatal, all the midwife, and anesthesia. So all those people have to be included on those training and transport team, whoever is transporting these patients. So definitely we're gonna need more than the number. And when I received the number from Muhimbili, when Madam Zuhura gave me, it was 219. So I'm assuming the other hospitals, it might not maybe 200, but it might be close to at least 100 and something, because those are 3 or 4 units. You should have more people who needs to get the training. And as I said, yeah, for us to change that in the newborn indicators, we have to have a bigger number than that. We have to have a bigger number than that, because otherwise we won't be able to change that.
Okay.
Yes, doctor, I understand that. Some of the authors have just brought me on the group of WhatsApp group. As Mwananyamala, they told me that I have 14 people. Mwananyamala, it was 36, and Muhimbili National Hospital, it was 290. But regarding the issue that we told us, I have to include the anesthesia people. Okay, as you can see that we have the ops and guide departments that contain a lot of nurses or midwives. So I think this number will change, and that will get up to you as soon as possible once I communicate with people from Bogoloni, Mwananyamala, and Temunich. So the number will change differently, yes.
Okay, perfect. That would be great because we do need, as I said, we do need a lot of people to come. And also knowing the number is going to help us when I'm putting people to come to either Muhimbili, they have 219. So chances is if that day or 2 days we are doing training in Muhimbili, more likely I'm going to need to have probably more than 5, 7, 10 people to be able to get a good group of people who can do the training hands-on, face-to-face, more effective than if there was only 30 people. So if there's only 30 people, I might send, okay, I can send only 2 people in that area. So I want to make sure the maximum number they can provide for us, it will help me logistically to plan how many volunteers are going to go to that hospital on that day. And if the hospital has the most people, more likely we might have to add, if there's 219 people, we might have to add 2-3 days to be able to accommodate that part. And if you have only 10 people, we might have to do only 1 day. So, I mean, there's a lot of logistic, and that's why we want to make sure we get the number. And if we really need to change those newborn indicators, that's usually my ultimate goal, other than the patient safety. My ultimate goal is to get every healthcare worker who is touching these babies, taking care of the postpartum moms, surgery-wise or delivery room-wise, they need to have training. They have to be able to have training. And we know nurses do not work by themselves, doctors do not work by themselves. So we have to work together, because if there's postpartum hemorrhage, nurse, doctors, anesthesia, lab, scribers, people are giving medication, they all have to work together. Pharmacy, they all have to work together for that one patient who is bleeding. The same thing for the baby. So we want all those interdisciplinary training. The group needs to be there so we can have. And that's why I really, and thank you, Mr. Mbida, for saying you're gonna add more people there, because we do need a lot of people to be able to, for these things to work.
Thank you, Dr. Gabon. I will welcome that as soon as possible and they'll give you the feedback.
Thank
That won't be a problem for me. I'll talk with the people from Buguruni, Mananyama, and the MNH. Because this also, sometimes they have the different departments. Some of them, they have maternity block independent, pediatric unit independent. I think in Muhimbili, you can see they have the pediatric unit independent. That can trace, they have sometimes that we call high dependency unity, HDU, NICU, and those people who are working in maternity block, they will start from the labor ward where they receive the baby for the first time. They stay on there. So I think we'll be having a large number of nurses and doctors and others that are working on those areas different. So we are dealing with the people that they come across with the baby directly after being born. That's the issue that we're discussing. So I will do that, and I will send you as soon as possible. I just communicate with those people. Thank you.
You're welcome. No, I appreciate it. Thank you very much. Yeah, but yeah, as I said, just to add it to it, is like, yeah, so we can focus on the people who are doing Help a Baby Breathe, but that baby is coming from the moms who needs to be prepared so baby can be healthy. So that's why we have to combine some of the training. So mom can come in with diabetic, bleeding, deliver the baby, go to the operating room, anesthesia needs to be involved. All those things have to work together, because otherwise one department is going to be trained, the other one is not. So then it's going to be decreased level of care, and that's not going to work. So yes, definitely, I agree with you. If we combine and plan ahead to make sure all these groups are working together, it will help to improve that care, definitely. So no, thank you very much.
What we need is just the continuity of care.
Yes.
To get the good outcome of the baby. That's all that we need.
Yes.
So
and that's, yes.
We are together. Yeah, we are together.
I appreciate that. Okay, so go ahead, Dr. Msambichaka.
Sure. I just wanted to add on to the fact that I think that head count will be very important to plan for the training sessions. In my discussions so far, it looks like the preferred training would be what was discussed, I think maybe 2 logistic meetings ago, where everybody goes to Muhimbili. And that is like the central training site, and then the other hospitals feed into it, you know, like Buguruni will send their patient staff, Wananyamala would send their staff as well. So if we know what the total number is, then we can, you know, dedicate like that entire week and figure out what the schedule would be to train all those people. I think that's the model that, based on my discussion. So what I was saying is the preferred training model right now is to have people go to a central location. So, you know, Buguruni, Wananyamala sends their people to Muhimbili. So if we remember like 2 or 3 meetings ago, I think Madame Zuhura was willing to have Muhimbili be the host hospital, but we were not sure if the other hospitals would be okay with that. But in my discussions so far, it seems like that would be the preferred model. And if we get the training scheduled ahead of time, then they can figure out their staffing ahead of time. They can figure out who's going on, you know, what day and what time slot. So having the total number of people will be very important for that planning, because then we can figure out and say, okay, we have X number of people. It's going to take us X number of days, X number of hours to get them trained.
Yes, thank you very much, Dr. Msambichaka. That makes sense, and that's what we wanted to know, the number of people. And if we're dedicating the first week to do all the training like that, and then the second week we have to go and do in the units, that's fine, because that also will help in a way that mobilizing the team, because we do have a lot of experts. And then so knowing that we're going to have 400 healthcare workers at Muhimbili at a certain time or which day or whatever, that will help definitely with the logistic and planning ahead. And that's what we want to know ahead of time, how many people can be, the maximum number of people that can attend, so we can address that and plan it accordingly and effectively cover those people, because that's what our goal is. So that would be good if we get those feedback, yeah. Anybody else has any questions? Jafaya, for what you've heard so far, any addition, feedback, updates from Muhimbili midwife section there?
So far, we are still on the same plan as we discussed before. So I think we good. We already shortlisted, but I have a list of midwives. That's the midwife and nurses that will participate on the training. So I have a list in my hand already.
Okay.
That's good.
Perfect. Yeah, so that's perfect. If you can send that list to Mr. Mbida and copy me, if that would be great, because we want to try to create a spreadsheet. So then if I know, I can just start itemize, because it will help for us to know. And also now we are gathering the supplies. We want to know if we're doing a large sum of people in one time, we have to have a number of sessions. I mean, you are a trainer, so you know all those hands-on training, the ratio for the facilitator and the trainees have to be a certain number. So if we are having a large number of group there, we have to have enough supplies to make sure everybody is able to touch and play around with the equipments. So we need to make sure everything is there. So, and that's why we need to know how many people, the head count, how many people are going to be there, so we can prepare with our equipments, like neonatally. We have to have enough neonatally for everybody to play around with that baby. Every single person who is going to show up there is going to touch that baby and perform whatever the series of the skills that we're going to prepare for them to do. And so
Absolutely.
when they come up there, yeah, so and when they come out there, we want to make sure every single person, there's no passive learning. Every single person have to touch that baby. Every single person have to be able to apply that bag and hold that CE, whatever technique. And I mean, we have to make sure they play around with it. So next time when they see the baby who is struggling, everybody should know, okay, I'm going to place my hand this way and I'm going to hold this way. So that's why knowing the number, it will help us get the supply, because we already start shipping some of the stuff now. And so it'll be good for us to know what we need to get there in time with us. So when we do the training, then we have things ready. So I appreciate all your feedbacks, and definitely it's gonna be exciting. I can't wait.
That's perfect. I'm happy to hear that.
Yes, it's gonna be, yes, exciting. And every time Mr. Jafari is saying the midwife and stuff, my head is like postpartum hemorrhage and stuff. So we need to slow that down. Yes. So, and once I know the number of those midwives, then we need to baby mommy you or whatever to do the proper training for those babies. I mean, moms, and for postpartum hemorrhage. So I'm excited. Okay, so I think things that we wanted for Mr. Saturini to respond, Mr. Mbanda, you've already provided those feedback and you're gonna work on it. That will be perfect. At the end of the meeting, I'm just gonna put a little takeaway for this meeting, and then so we can work on it for next meetings. So let me see my other.
Yes, we are together.
Yes. The next business was to do the getting the target number to discuss how many attendees we each hospital is agreeing to send, which I think Dr. Msambichaka just touched on it. The preferred mode of training right now, it's bring on one location, which we discussed earlier, but so the next questions which I had for today, we don't need to cover that because it's going to be covered by the response that Mr. Jafari already provided, say he has the numbers already. I think the one thing just left is the virtual, just emphasis on the virtual training right now. We do have all those 3 sessions done now. The next sessions are coming, hypoglycemic, postpartum hemorrhage, newborn, sorry, diabetic screening. So those training also are coming. We want more people to come and get the theory part of it. And we still ask people from each hospital to participate on the training, so then at least they can share their best practice now or current practice. So you'll be able to, when you are teaching or providing training, we can address things that are applying, are happening right now in Tanzania. So we're gonna still continue reaching over and get information from different people. And I ask for your cooperation and give us feedback. So for those training, so when we do the training, it's more applicable for you guys and we can work. Any questions? And I think that's what I have for now. Any questions you guys have about the logistic stuff? So any other questions? So as of now, Mr. Mbinda, thank you very much for giving us the responses for what we were asking. So we do have a lot of answered questions now. And then, so referral protocols, so you're going to help us gather the Buguruni, Mwananyamala, and Muhimbili. Even if they're different, that's okay. We just need to know which levels of care they do. And then we can itemize like the education. Another place for the newborn indicators. So we do know that we do need a number of people to, a large number of people to attend the clinical, the training to improve the clinical skills. And you already addressed that. You're going to add those numbers. So thank you very much. We already talk about the face-to-face training, and that's the preferred mode right now. So we just need to get those numbers so logistically we can plan. So hopefully if I get those numbers before the next meeting, we can have at least a little sample of how we're going to go through the education purposes. So, if it's a week, so then people will have, for Muhimbili, Buguruni, and Mwananyamala, you have an idea of like, okay, each day, how many people do you need to send? And then, so that also will help me to see all our volunteers, how many people can attend in each day and how many number of attendees should be there. So I think that would be great if we get those feedback as soon as we can. And then one last thing is if we can get the current statistic for the newborn indicators outcome, but I know Mr. Saturini was supposed to give it to us. But yeah, so we need to know where we are starting with. So if it's, I'm just giving an example. Let's say the neonatal mortality is, I don't know, 15 or 20 or 30 or 50, or hopefully not 50, 15. So then if we're 15, then we need to see how can we break it down from 15 to, I don't know, 13 and then 12 to try and identify things that we could address during the training. Also, we can inject that information to try and address the needs. And then I think those stats we were supposed to give us, like which hospitals, and then like if they have age, like gestational age, if they're premature or full term, or what are the diagnoses at the delivery. Or I think there was one of them was for fresh stillbirth. So we need to know if that patient was receiving care or not. Whatever the information that is there with the statistic right now, that's what we want to be able to have. And so we can build on from our planning, because this is going to be, as I said, we want to move that dial. So we need to know where we start with before we continue teaching and without knowing what the percentages we are working on. Does that make any sense, Mr. Mbinda?
Yes, I understand you a lot, okay. Dr. Gabon, and we are together. I'll just work on that. Okay. There's some issue that I have to do some researches and ask the other stage people. But regarding the issue of the mortality rate, that's different from different literatures, and not much research has been done on that. So I think I'll come with the good thing at the end of this.
Yes, which is, you raised an excellent point. Yes, because it's going to be different level, different location, which I understand. And we have to have what you guys use as a definition. So we base on your definition, and then we put the evidence-based definition of neonatal mortality, and then we build from that. Because we have to be able to make sure whatever you guys were comparing of, that's what the definition currently is. And then we have to, if we are going to develop the data from now on, we're going to use the new evidence-based whatever definition. So we know where we are starting. So whatever you guys have, that'll be good. Yes.
That's the one.
And then, yeah, and we discuss more. I know you're on the research side of that, which I already love research. So we're going to discuss more on the side meetings, because it is a big deal. I mean, changing those numbers is a big deal. There's so many factors, confounding factors, things that we change the trajectories, location, the training we're talking about. We're addressing a very small part of the training, but there's a bigger part which affect that number. So we have to be able to get as much risk factors or identify as things that we can change or modify to try and change that number. We're not going to fix it in a day. And that's why this could be 5-10 years from now, but still we need to move somewhere, positively moving to the right direction. So so the more information we have, it will help us building the better foundation of that project to be able to move it. Yes.
I'll work on that as soon as possible.
Okay, thank you. So if we don't have anything else, Mr. Jafari, final words, Dr. Msambichak. Oh, I'm sorry, I see your hand, Dr. Msambichak.
I have a request from for Mr. Mbida. And I'm not sure if you'll be able to provide this information or not. What I would like to know is what is the standard, the transport standard that has been set by the ministry. So when a patient is being specific to newborns, when a newborn is being transferred, let's say from Wananyamala to Muhimbili, what is the expected standard of transporting that newborn? Because the standard versus the reality is, and probably Dr. Mushiro might appreciate this, and Dr. Akita, if you have a newborn at Wananyamala who is on CPAP and is decompensating, and that newborn needs to be transferred to Muhimbili for higher level care, the current transfer process is you take that newborn, you get the ambulance, but then because you don't have a CPAP machine, you put them on nasal cannula and get them to Muhimbili. I mean, that is like, I'm not sure what the outcome is when Dr. Mushiro usually gets these kinds of transfers, but so that I would like to know, what is the ministry standard versus what's actually happening? Because maybe there's potential, obviously not now, but in the future to figure out how do we fix that part. Because if I'm transferring to a higher level care, I'm de-escalating care, then expecting survival, 20 minutes if a kid is in, a newborn is in RTS, is probably not, it's not good. Even if they survive, I'm assuming they have neurologic sequela from that. So I'm just curious if there's, if there's information out there, or maybe that's an area that has not been looked into and there's potential to look into it as something that can be enhanced in the future. Thank you.
Yes, if I can add to what
yes, Dr. Mushiro, go ahead.
If I can add to what Dr. Msambichaka has been, commenting on, she's very right. I am also not sure that what are the standards of the ministry, but what I know, the ministry knows that they don't have a proper way of transporting patients, be it an adult or if it's a child or a newborn. The ambulances that they are being used to transfer patients, they have very, very minimal support of patients. The least that they have is an oxygen cylinder, and they can only do oxygen by as a nasal cannula or maybe by face mask. That's it, and then you won't find any other support the patient that might actually get during the transportation. And so to overcome this, previously, all the district hospitals, at that time, they didn't have proper neonatal units, I remember. The protocol was, for example, if they have a woman in preterm labor, they refer that woman to deliver at Muhimbili. So that was the protocol at the time, because we knew that once you have a delivery somewhere else, the transporting part, it's going to be a problem, and we end up having a very, very poor outcome. And I think 2 years ago, we had one of the residents at Muhimbili. He looked at all the referral cases that were referred from different hospitals. I don't remember the numbers, but the numbers were not good in terms of survival. So as we speak at Muhimbili, of course, we have around 40% of our admissions are outbounds, but these ones, they contribute more than 60% of the deaths of all in the newborn unit. That's what I can share right now.
That's exactly what I was talking about. And thank you very much, Dr. Msambichaka, for the question. And thank you very much for Dr. Moshiro for elaborating on that question. That is exactly what I was talking about. If the baby is being transferred from one area, what is the nurse or whoever is transporting that baby should do that 20 minutes to 35 minutes to transfer that baby to the higher level of care. So yes, they're in different levels, but that nurse from the lower level needs to know basic things that they need to keep that baby alive until they get there. So if, like what Dr. Msambichaka gave an example, that from the CPAP, you go to the nasal cannula, there's a reason the baby was in the CPAP. So you're gonna take it out and give it nasal cannula and then transport that's 20 minutes, 35 minutes. That baby, even if the baby physically arrive to the new hospitals, the outcome is not going to be great. And Dr. Moshiro just said 40% they're born outside. So those 40%, that's the risk factor already. Those 40% comes to the hospital and contribute to the 60% of neonatal mortality. That's the part we need to know. How can we address if that 40% is that the people cannot come to the hospital because they don't have transportation, or people deliver at home, or people deliver at the dispensary and then come to the hospital was already too late, complication-wise, or there was not screening during the pregnancy. So all those things are so many factors, but we need to be able to group them. So when you are moving that dial of the, for trying to identify those neonatal outcome, that's the part we need to know. How can we reduce that 40% from delivering outside the hospital and then come back to the hospital, when they have more complications like that. So those are the things that when we get those statistics, it will help us when we are teaching. We're not just focusing on only transport. Transport is a big thing because the patient is already at the hospital. So they should be expecting the basic care there, which to keep them alive until they get to the higher level of care. So, and that's the part which I know Dr. Msambichaka raised a good question, ministry standards and current practice. So we want to be able to know, to go to the unit and see exactly what is happening. Knowing the protocol ahead of time will be great, so we can at least start identify or itemize things that we think we need to be able to discuss and share with you guys. But we need to be able to have something that we can base on those care. Like if we go to Buguruni, these are the basic things that the baby should get. We go to Mwananyamala, this is the basic things that the baby should get. We go to the Muhimbili, even if it's a referral hospital, these are the basic things that they should get, and then add the level 3 or whatever the referral hospital needs to do. But still, when you're transferring the baby, that baby needs, there's a reason you're transferring that baby, and the baby needs to get the best, better care than even staying in that same hospital. So all those things are the ones that we are trying to address. I know it's so much, but we can try as much as we can. The more we address, the more we're going to increase the knowledge, and it's going to help that baby, that one baby. If we can save the life of that one baby, then we can save the life of many. So that's why we need to keep working and discussing and addressing and identify those risk factors. Because majority of them, yes, it's knowledge, Majority of them also is equipment, but largest of it is how you take care of that patient. The clinical application of that, every single person, healthcare worker who is touching that baby or is touching that mom. Yes.
Thanks a lot for the explanation. In fact, the issue has just touched me a lot from Dr. Msambichaka. These protocols, you can see that the protocols are different from different areas. You can see that the Mwimbi is just a national hospital, so it means that some of the issues are more improved compared to Buguluni and Mwananyamala. So if they send the baby from one place to another, example, if you take a baby from Buguluni and goes to Mwimbi, it means that that baby needs much care. That's present in Buguluni, but it's there in Mwimbi. So the matter is how that baby is being transported from one place to another. So what kind of car, what kind of trainer is going to escort that baby from that area? So I think this would be a great issue in your country. I appreciate that. Thanks to Dr. Msambichaka. And then I think we have to, we as a ministry have to deal with these protocols or to review them, because I think different places like maybe they have them, so they maybe if they want to receive a certain kind of baby, they have the issue of just getting a phone from one place to another. That's why bringing a certain baby. So that is, I think I just talk with the people from Mwananyamala, Mwimbi, and Buguni, and then I just come up with those issues that directly, the protocol that happened. Regarding the protocols that we have, I was talking regarding that the Mwimbi is a national hospital, they have improved services on some of the issues. That you can see that most of the referrals are coming from those areas, that maybe from Wanyama Buguntu to Mwimbi. So it's just the standard of looking on the way that baby is moving from one place to another, what care that baby is being given, and what kind of person maybe is he trained or is she trained on that issues of managing that baby regarding the condition that is being sent from to Mwimbili or somebody else. So I think this Dr. Msambichaka has been raised a very critical issue that we have to work together. And if we have the protocol together that we share from different people to another, if they are the same, it means that we'll be working together in every aspect, no matter where the baby is come from. That's my condition. Thank you.
That's what we want to make sure we get the most information. The more we learn, the more we can get to the roots of the this source of the complications. And then if we can address them, it will be easier to, like make it more effective. So even if the nurses and doctors know what they're doing, at least the logistic part, okay, knowing those protocols. Because yes, you can have those protocols, but if nobody's practicing it, then well, it's not helping anyone. But yeah, so definitely having those protocols will help, even if they are not, I mean, they are different, but whatever the current practice is, that's what we have to start from. Because yes, and then if the protocols written somewhere, that's fine. Then we can try to mirror those protocols and try to improve and make it at least basic standing transfer paperwork to, if every single patient who is transferred should have certain things done, and then transfer from the higher level of care. So it would be nice to know those things. So I guess we have a lot of work to do.
Yes, I agree that.
But that's good. We can do it. We can do it. And that's why the reason. And I thank you everybody for being here and asking those appropriate questions. And we can learn and try to improve and save our fellow Tanzanian. All these babies and moms and every patient require our undivided attention and all the ultimate skills from us to be able to save their lives. So we need to do that for them. So. So if nobody has anything to say, Mr. Mbida, do you have any final words to say before I let everybody go?
Also, I would say this was my first time joining with you. I really appreciate that. And that's how I have to promise you that I will work together with you hand in hand till we accomplish this matter. Because I really love the newborns, and then I think you know what I've did in just my research and everything else. I understand there were a lot of issues on this area, and if we work together like we are doing now, cooperating with other peoples, I think a lot of areas they have these people not at Mwananyamala only, Mwimbili, and we have to to do this thing in all of our countries in different places, because the matter is the issue that counts is just the issue of the hand-on skills start from the way somebody will get trained, the training issues from the universities, the different levels, and then if you come to the areas that of working, the rate of issues that compromise that issue. That's why I just, if we discuss together like this, share the experience from Wimbili, Buguluni, Mwananyamala, and then we know what we will do for the next areas. So we started from this also, and then I think we go further more. And this area there was, I can say, a populated areas more like Dar es Salaam, Dodoma. We get a lot of problems like this. There's people that are prepared because you know the high number. You can see that the high number that the countries that get, let's say the regions that are high number of delivered, you can see that they have a lot of problems in these areas compared to the areas that do not have high number of deliveries. So I think I really appreciate you for joining with me today, and I've learned a lot. And I promise you that I'll open there as soon as possible and give the feedback, and then we just go to the next issues. Thank you a lot, all members.
No, thank you. We are honored with your presence, and we did learn quite a bit. And as I said, we're going to continue learning and do our exchange. But just to add that QHSC decided to do the training. I mean, we've done the medical mission before where we just come and show up in a week or 2 weeks, do the care in the hospital, training and stuff, and then leave. We've done that already 3 times. But then we realized that the need increases. And if you come and teach and then leave, then people decide, I mean, after you leave, they wait until the next year you come back. So this year we were like, no, we need to make sure we have that continuation. And because the education doesn't end in once a year. No, it has to be continuous. So that's why we wanted to do the annual, like we do it before we come to the medical mission, and then in the medical mission, we come and validate and stuff. So we can hang out with our colleagues and learn even more things that we can address. But also in doing that, we need to be able to make sure people are coming. And that's why the logistic meeting comes like that. And we appreciate people who have position to give either make the decision are involved in this planning and logistic meetings. So we appreciate you coming in, and send our regards to Mr. Saturini Manangwa, and thank you very much for coming and answer our questions. But we have a lot of questions. Dr. Msambichaka is there, Dr. Akida, Ms. Valentines, and Mr. Jafari, and Mr. Gabor, and Mr. Siakabe also. So thank you for coming and be able to try and address a little bit at a time. So haba na haba, hujaza kibaba. Taratibu.
That's what I was just about to say. You took it from me.
So a little bit at a time, we're gonna get there. We're gonna get there. We're not going to let it slide because our family members are there. So we are a little biased because our family members are there and the friends and stuff. So we do want and make sure everybody gets the best care possible. Yes, we selected these 3 hospitals for a reason. Level 1, level 2, level 3, and according to our standard, usually say level 1. You guys call the health center or mid-level, and the referral hospital, that's fine. But we usually call level 1, 2, and 3 for level of acuity and how it needs to be done. So, and these 3 are piloting. So we are not done yet. We're going to come to the whole country and everywhere in the world where they can listen to us. That's fine. But we're going to start with those 3. And then so we don't want to learn as much as we can. And what we learn for Buguruni is immensely. It helps us to know if level 1 or the health center, what do they do? We want to know that, even transfer, but those are always going to end up to transfer. So addressing the transfer part is huge. Yes, our focus on the newborn, our focus on postpartum, moms or pregnant women, because we have unnecessary death. For both of those groups, we have unnecessary death. I know some of the ones we can protect, even here in the United States, we do lose moms, we do lose babies, but people will do everything they can to make sure it doesn't happen. And if it happens, everybody scratch their head. Health department, we've never hear, even if you say you lose 1 mom for the whole year, they're gonna come and you have training for until tomorrow. So we wanna make sure Tanzania eventually gets to that role that we don't have unnecessary deaths, or we don't have those preventable deaths for moms and newborn unless something catastrophic happened. But so one we can start with is training and training and training. So we are all passionate, we are all focused, and we really want to make sure our family members are safe and protected, and every single person in Tanzania get the best care possible.
Okay, nasema kwamba ni asante sana na tuko pamoja. Alita continue kwenye hili.
Yes,
Tutafanya
Alita
pamoja.
continue.
We are together in this till everything is okay.
Okay, thank you very much, guys. Dr. Msambichaka, Dr. Akida, Mr. Jafari, Mr. Gaboni, Mr. Siakabe, anything? Anybody can come and say hi and wave so we can say thank you for everybody. Miss Valentine is
Thanks
hiding.
for all you do, everyone. Have a happy day.
Thank you. Okay, bye, guys. We'll send you the recording, yeah, when it's done, yeah.
Okay. Bye-bye.
Okay.
Bye.
Bye and good night.
Bye-bye.
Thank you. Oh yeah, you a good night. We still have to look for lunch. Right now, saa sita na nusu mchana. We need to eat.
That's what the word is going around. They say.
Yes. 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 No, thank you. Thank you very much. Yeah.
Thanks a lot to Dr. Gabon. I
Okay,
appreciate that.
asante. Okay, asante.